Tonight we have a webinar on type 2 diabetes and new treatments on the horizon. Now this webinar is kindly supported by Boehringer Ingelheim and Lilly with an independent medical education grant. My name is Dr. Grace Lee. I'm a general practitioner and I'll be moderating this session tonight. Tonight we have Dr. Ole Schmiedel, who has kindly stepped in to talk to us today, as Dr. Rinky Murphy is unfortunately unable to join us. Now, Dr. Schmiedel is a physician and endocrinologist at Auckland Diabetes Centre in Green Lane.
Yeah, good evening, everyone. So I speak to you from the Green Lane Clinical Centre. So this evening, as Grace already alluded to, will be about the new diabetes medications. Right, so that's the structure for today. So we talk about the mechanism of action for each of the drugs. Then we talk a little bit about evidence, safe prescribing, and I will give you a clinical case, and then we are open to question. But I just want to start off with the background. And when we treated diabetes in the past, we were mainly concerned about good glycemic control. Now, we know that it is more than just good glycemic control, what really makes a difference for good diabetes management. So not only is it the full assessment and finding the right medication for the right patient, agreeing on a management plan and doing all these things that bring you to the goal of care, but also specifically looking on to cardiovascular risk and benefit and using medication that actually reduce cardiovascular risk, reduce progression of renal disease. And so we have a new guidance which came out in 2019 from a joint meeting from the European and American Diabetes Societies. And this guidance is now also the backbone for the new diabetes guideline that's currently developed by NZSSD and should be available in early 2021. As you see on the left side, you have mainly patients that have already established cardiovascular disease or have heart failure and renal impairment. Then you have in the center in yellow people or patients where you want to minimize hypoglycemia. Then you have the group where weight loss is predominantly your target. And then you have on the corner where we are at the moment where cost is a limiting factor. As you see at the beginning, for any treatment, the start is with lifestyle measures and metformin. And then you either go down either part of either of these groups. So to put a little bit more in detail, you see the pathway where we have established cardiovascular disease. Again, it starts with metformin. And then it goes down when it's predominantly cardiovascular disease. You start a GLP-1 agonist or an SGLT2 inhibitor. If it's predominantly heart failure, then the SGLT2 inhibitors are the preferred medication, and we will talk why this is. If you talk about weight loss again, these two drugs come in because they have proven weight loss benefit. And that is really, in a simplified ways, when you look at it, assess the cardiovascular risk, start with metformin, and then look into which side you want to go, whether it's cardiovascular disease or heart failure and CKD. So fairly straightforward guidelines. Now that's where we are at the moment, and I just put the slide in to show you that the medication we use at the moment is well established. That's metformin is nearly 70 years old. Sulfonylurea was introduced at the same time. And the medication we're talking tonight about SGLT2 inhibitors and GLP-1 agonists actually aren't new medication. So they are roughly either for the GLP-1 15 years, for the SGLT2 7 years. So there's loads and loads of evidence and experience in the use of this medication. And I will show you how we can actually use what has been learned internationally for us when this medication becomes funded. Just to let you know, there are a number of other activities that are currently ongoing. So I already alluded to the NZSSD guidelines, so the update. We are awaiting the PHARMAC decision, as you all know. And there's to be published a PricewaterhouseCoopers report on the cost of diabetes, looking really into early intervention and what the economic impact is from early intervention in diabetes. And there will be an update on the healthcare pathways and a number of other platforms and documentations to help you with the management of patients when this medication becomes available. So now, to understand, put it in the right context, it's good to actually group the pathophysiology of type 2 diabetes by the different organs, a little bit like you would do with blood pressure. So you have deficient insulin secretion or increased glucagon secretion, so you have your insulin sulfonylurea. You have your insulin resistance, so you talk about on the muscle, on the liver, on the fat, your TZDs and your metformin. You have the GLP-1s and DPP-4s who work really on the incretin effect in the gut. And then, of course, you have the SGLT2 inhibitor, which predominantly work on the kidney. And so if you group them, it makes it much easier. So you have basically one group GLP-1, DPP-4, one insulin SUs, and one metformin, TZD, and another one SGLT2. So really clarifies the use of the different medication and also tells you that you can actually add on. So you have several medications that you can add on before you need to start insulin. Now, coming to the first group of the medication, the SGLT2 inhibitors. What do they do? They basically reduce the absorption of sodium and glucose on the proximal tubule in the kidney. So the majority of glucose that get filtered get reabsorbed. Otherwise, you would have glucoseuria. So we basically here create glucoseuria deliberately and cause increased urinary glucose excretion. And since sodium is excreted at the same time, you get also natriuresis, and therefore you get the other benefits, especially for heart failure. So now this slide is quite a busy slide, but it tells you that you actually have multiple flow-on effects from natriuresis and glucoseuria. So you see that the plasma volume reduces, that has positive effects on the myocardial stretch and ventricular arrhythmias. It has benefit on vasoconstriction, and the intraglomerular pressure is reduced. So they work basically in synergy with UACE inhibitors on preserving renal function by reducing the intraglomerular pressure. They reduce the blood pressure, reduce arterial stiffness, and also cause volume concentration. For example, the hemoglobin goes up as one side effect. And of course, the glucoseuria has the effect on HbA1c inflammation and other effects, as you can see on the slide. Now, as I mentioned, SGLT2 inhibitors are not new medications, and there's a number of medications available. So we have empagliflozin, canagliflozin, dapagliflozin, and ertugliflozin. So in each of them had large cardiovascular outcome trials. So as you're probably aware, we have currently dapagliflozin available, and PHARMAC funding is proposed for empagliflozin. Now, I will focus tonight on empagliflozin because that's a medication that hopefully will be funded beginning of next year. So that's the largest study. You see 7,000 patients. Only 10% had a history of heart failure, 25% had an eGFR under 60, and the mean duration was roughly 3 years. And that are the data lots and lots of people have talked about. The major outcome from the EMPA-REG trial. And as you can see here, there was a significant reduction in the primary outcome, a very significant reduction from cardiovascular causes, deaths from any cause, and hospitalization for heart failure. So as I told you at the beginning, this medication not only reduces blood glucose, but what they do, they reduce cardiovascular deaths, they reduce hospitalization. and they have also a small weight loss effect. Now, there were a number of large post-hoc studies, as you can see here, 140,000 patients in the US, so overall 200,000 patients, and it showed a significant benefit on all-cause mortality. Equally in another study that looked into heart failure outcome, again, 300,000 patients, significant benefit. So not only in a registration study, but also in the large post-hoc analysis, significant benefit. Now, this is now a meta-analysis of different studies that were done, and PHARMAC I already showed you. There's the CANVAS trial and the DECLARE-TIMI study, and again, so all these studies together clearly improved or reduced the cardiovascular outcomes and improved survival. Now, if you look across the different medications within the group, all have an efficiency as mentioned. However, the PHARMAC study was the only one that found significant cardiovascular death reduction, and therefore we're very favorable, or we're in a very good position if empagliflozin gets funded. All have consistent effect on heart failure, and equally there was renal benefit across the group. So that is an interesting study I put in there as well, because it looked into dapagliflozin, DAPA heart failure, for patients who did not have type 2 diabetes. And there was a lot of debate recently about whether this medication should be used outside of diabetes. So the current licensing criteria in New Zealand really stipulates type 2 diabetes, but there's international debate whether SGLT2 inhibitors are also used for patients with heart failure. And this study really showed a significant primary composite outcome for cardiovascular death, hospitalization, and heart failure for dapagliflozin, with a relatively low number needed to treat at 21, so significant benefit. And as you can see in this slide, there was no difference whether you had type 2 diabetes at baseline or not. So the effect was independent of type 2 diabetes and therefore independent of blood glucose lowering. Most likely due to the diuretic effect that we already alluded to, and probably through a number of other benefits. And that was a significant other finding, that was all-cause death. So using dapagliflozin in this context reduces the all-cause death, which is a significant achievement for a medication. Now, this study was recently published, the last one of the evidence I want to show you, in October this year, that looked into cardiovascular and renal outcome with empagliflozin in heart failure. And here you again can see that in this study, you found with empagliflozin this time a significant reduction in the cumulative incidence, all-cause outcome of the composite outcome. And again, you see here in the slide the significant reduction for heart failure hospitalization. So both DAPA and empagliflozin have good outcome data for all-cause mortality as well as heart failure hospitalization. And that's another interesting finding. Roughly a year, 2 years ago, when we got vildagliptin funded, the combination of enalapril and neprilysin inhibitor was funded by PHARMAC, which is far more expensive than, for example, dapagliflozin. And you can see here that actually dapagliflozin had a significant greater impact on cardiovascular death and hospitalization than actually the combination of enalapril and sacubitril. Valsartan sacubitril. So that's the other slide I wanted to show you. It's about renal outcomes. As you can see in this slide, there is a transient drop in eGFR, which over time actually preserves outcome, preserves renal function. So it's a little bit like when you start with an ACE inhibitor. You see a transient drop in eGFR, And thereafter, you see renal benefit, stabilization of eGFR. And I told you already, the main underlying mechanism is by reduction of the intraglomerular pressure. And that's really a slide that illustrates it, that you basically have a backward effect from the distal convoluted tube onto the arteriola in the glomerulus. And that's really the way how it reduces hyperfiltration and glomerular pressure. These are some slides I borrowed from Wing Chan and shows you the different prevalence and progression of renal impairment in different ethnicities in New Zealand. And what is highlighted here, that's the standardized ratio for dialysis in 2009 in the country's Manukau area was 18 times for Pacifica compared with the standard population European. And you can see it in this slide that you basically, in orange, you see the Pacifica in much earlier onset of end-stage renal disease, so in a relatively early age compared with other ethnicities. And here you see patients that receive dialysis, a significant higher number of Maori, and interesting enough, other Asian who actually end up on dialysis. So to close this off for the SGLT2 inhibitor, I wanted to give you one case. So Sue is a 63-year-old female who I saw in clinic. She had type 2 diabetes for a long time. She was on insulin since 2005. She had multiple diabetes-related complications, as you can read there, retinopathy, neuropathy, and microvenuria. She also had fatty liver with features of the metabolic syndrome, and she was seen in the liver clinic, and she had a FibroScan consistent with severe fibrosis. She was on the standard treatment that most of your patients probably have these days. So she was on Lantus and Apidra as a basal bolus insulin. She was on Galvamed, quinapril aspirin, atorvastatin, and a fibrate. So her H1C was 80. She had mildly abnormal liver tests, as already mentioned. She had normal renal function after many years, which was good. She had an increased cardiovascular risk, and she had microvenuria. So what did we do? So we increased her metformin to the maximum tolerated dose because she had normal renal function, and we agreed to add an SGLT2 inhibitor. So at this time, the available one was dapagliflozin, but you can equally start empagliflozin with the same indication as I did there. So we were able to reduce her insulin later on, and we explained to her that this SGLT2 inhibitor, which she had to pay, really improved her glycemic control, weight management, cardiovascular benefit, and the beneficial effect of microvenuria. And as you can see here, that's what we normally achieve. So she was started in 2020. So when she was on an H1C of 80, which gone down to 72. So not a significant achievement, not a target at this point. However, a move in the right direction, also supported by her using now less insulin than she had before, and a significant improvement in the microvenuria. Now, what you need to be aware when you start this medication. SGLT2 inhibitors are a little bit more difficult to start than your vildagliptin, the DPP4 inhibitor, because you have more side effects. So you can get UTIs and thrush. You can get a rare condition, necrotizing fasciitis of the perineum, Fournier's gangrene. You can see the transient decline in eGFR, so you need to monitor, and you need to avoid volume depletion because it can lead to hypertension. And the rare condition I think a lot of people talked about is euglycemic DKA, i.e. we avoid them in type 1, and we need to educate patients about it. And we're trying to avoid hypoglycemia by reducing sulfonylurea and insulin. This slide really sums it up, so you will have access to the slides. You can see the side effects, but it's important to be aware of the side effects. And that's really, I'll leave you with the last slide. as a learning point, and then we might be able to go into the question and answer session, just to say that empagliflozin has 2 doses, 10 and 25 milligrams. You start on the 10 milligrams, and if required, you go up to 25 milligrams. It can be used with an eGFR down to 30. There's no adjustment for patients with hepatic impairment. It's not really recommended over 85, and we have little evidence over 75. And you look out for these side effects and complications that we already mentioned. And you don't use it in pregnancy and breastfeeding.
Okay, that's a great summary and some great take-home points. It's fabulous, actually. You've answered some of those questions that were coming to the fore, so that's really useful. If we could just pick out some of the side effects, for example, the UTIs, that's something that's really common that we manage in general practice. And just your sort of thoughts around UTIs within themselves are relatively common.
Mm-hmm.
How many episodes of UTIs would you tolerate, or would you allow your patient to tolerate before you would say that's probably enough, this is probably end of trial of treatment?
Mm-hmm. That means first I educate patients. So we know that UTIs is more common in ladies than in men. We know it is more common if you had a previous UTI. And we know it is probably more common if you had any anatomical changes to your perineum. So that is something to be aware before. I tell them that you treat the first UTI. A lot of patients wish to stop the medication while they treat it, but there's actually no evidence that you have to stop it. So you can continue. I would say after the second UTI, it is probably a good time to consider a different medication, because after you had a second UTI, it is highly likely that you get further ones, and then it is a risk. The biggest risk is for people who do not recognize it. So there will be people who have symptoms and don't present, and I've seen people who develop pyelonephritis from it. So yes, it is important to educate patients at the beginning, treat appropriately, and act when there is progression.
Okay, all right. And if you wouldn't mind just expanding, or perhaps if we just shift back to your previous slide, if we can, if that's possible.
Oh,
sorry.
Are you doing this from your side, or do I do it? No?
No, that's you currently are sharing your screen.
Okay, so maybe that goes this one. Oh yeah, that goes back. Which one this?
The one just before.
Yes.
Perfect. Okay. Now, could you just expand a little bit on the use of prophylaxis treatment for UTIs? You've got one listed treatment there. Would you consider any others? If you could just talk us through that.
Okay, so that is probably something more for primary care. So Hiprex is available in New Zealand. I have not used it. So I basically would treat with antibiotics. That's how I normally do it. So I treat with antibiotics, some trimethoprim or a penicillin-based treatment as per normal antibiotic protocol. And Hiprex is available and can be tried, but again, there's no real evidence in this context available.
Okay, great. And if we just remain on that slide for just a minute, that's one of those slides that have prompted quite a few questions that'll be lovely to go over. Now, the euglycemic DKA, that's something that I would say many of us, it feels counterintuitive, and it's not something that many of us would have necessarily come across. So the question really around that would be, firstly, just thinking in mind, our audience today would be relatively broad. If you could just remind us of some of the symptoms that we should be thinking of in order to educate our patients. And secondly, someone's got a really good question with regards to ketones. Would you suggest that people that are on these medications need a monitor, or is that something that we should be having within our practice, and we should just be reminding our patients of the symptoms so then they can come to us to get checked?
Okay, thank you for the question. So I think the first answer is it's a very rare complication. So the main message is, again, educate patients that it could happen. Now, how it presents is basically with abdominal pain and general constitutional symptoms like a normal DKA would probably present. And you will have ketones, but you will have a normal blood sugar or a near normal blood sugar. Why does it happen? Because when you excrete more glucose in the urine, you will use ketones. You will generate ketone bodies to use ketone bodies for cellular metabolism. So that's why it's, for example, contraindicated in type 1. I wouldn't use it in people who have LADA or latent autoimmune diabetes of the adult. And it can basically come relatively out of the blue, but generally there is a precipitating event. So there could be people who are trying to lose weight, people who go on ketogenic diets, people who get admitted to hospitals. We recently revised the hospital guidelines to say that people who go for procedures that can lead to dehydration or prolonged starvation, that these patients stop their SGLT2 inhibitors. So yes, there's often a precipitating event, and then the symptoms as mentioned. Now about monitoring ketones, we do not recommend that all patients on SGLT2 inhibitors have ketone meters. That clearly would blow the budget, and it is not necessary because it's a very rare one. However, we educate all the doctors in hospital to be aware of this. And I think if your patient is aware of the symptoms, then most patients will act accordingly.
Okay, great. And that leads us or lends us to really the renal function. So we've got a few questions there. Someone's wanting to know, you talked about that transient drop in the EGFR. What is an acceptable level that we would tolerate it going down to?
Again, there is a little bit difference between the different SGLT2 inhibitors and different guidelines where you look in. But I would say for primary care at this point, probably a 10 milliliter drop would be acceptable. So what is important to monitor UTIs, monitor renal function, and watch out for dehydration. So if patients, for example, on 1 or 2 diuretics, if they develop diarrhea, vomiting, or as on the slide, go for bowel clearance, then it might, or it's often necessary to stop the medication. So watch out for dehydration, which would lead you to a kind of a pre-renal picture with reduced volume circulation through the kidney. But up to 10 millimeters is fine.
Okay, we'll do one last renal question and then we will continue on. We've got some good questions that have also come in, but I'll try and group those towards the end of the next section. With the empagliflozin, someone was just commenting on the fact that the Australian data sheet suggests that we perhaps shouldn't use it below 45 mils per minute, and just wondering if you could comment on that. Okay,
so it's a very good point because every data sheet shows you slightly different. So what I did is where I got it from is from the New Zealand data sheet, which is available, so you can actually Google it. Now, when you look onto the other New Zealand data sheet, which is for dapagliflozin, it says 45. Now, how does this come about? Because when people started using this medication, we were very concerned about renal impairment, because when your kidney doesn't work, you don't excrete much glucose. Or we were worried about the transient worsening of renal function and of dehydration. Now, people have studied them down to EGFRs of 20-25. So therefore, as we get more experience with the medication, the different data sheets probably got more liberal. So the 30 is from the New Zealand data sheet for empagliflozin, and the current New Zealand for dapagliflozin shows 45.
Okay, fabulous. So we'll carry on to the next section. Thank you.
So see whether we come to the next section. Okay. All right. So the next section is the other group of diabetes medication. So as we just gone through, I will start with the background mechanism. And then I will guide you through some evidence and then some practical steps. So these therapies actually have been around for, as I mentioned at the beginning, probably 15 years. GLP-1 are hormones that are excreted from the L cells in the ileum and the colon in response to nutrient entry. And what they do, they stimulate insulin secretion, they suppress glucagon secretion, they inhibit gastric emptying, and they reduce appetite on food intake because they also work on the hypothalamus. And so that's really a cartoon that shows you the different effects. So on the pancreas, on the gastric excretion, on the brain, as well as on the liver. Now, this is an important slide to understand actually how they work. You see on the left side, plasma glucose. On the right side, you see the C-peptide response as a equivalent for insulin response. So when you give glucose orally or intravenously, you match the two curves. But when you look onto the insulin response, you see much less response when the glucose is given intravenously than when you give it orally. So something is happening when the glucose comes orally that actually leads to increased insulin excretion. And that is really due to the GLP-1 hormones. Now, the GLP-1 hormones have only a very short half-life. So the medications that we use are basically mimetics. So based on the normal GLP-1 that allows a longer half-life. Now that's another interesting fact. So on the left is a graph I just showed you. So between the oral and the intravenous glucose and the insulin response. On the other side, you see in a patient with type 2 diabetes. So this response is blunted. And what you often see that is really expresses itself in the blunted first phase insulin response, one of the things that often get lost in diabetes quite early on. So what are the medications available? So you see internationally on the right side, we have exenatide, we have liraglutide in 2 doses. We have semaglutide, which is available subcutaneously and as tablet form now. We have lixisenatide and dulaglutide. So in New Zealand at the moment, we have exenatide and the long-acting exenatide available, self-funded. We have liraglutide as a 3 milligrams recently launched for weight management. We hopefully will get dulaglutide. So this evening, really be focusing on dulaglutide because that's a proposed funded GLP-1 agonist from PHARMAC. So that's really taken from the early slides, but all the GLP-1 agonists have very similar side effects. So the majority of side effects is really nausea, vomiting, and diarrhea. So GI side effects. All the other ones are relatively rare and not much significant differently from placebo. When to use this medication? So as I showed you very much at the beginning, it's used in patients who have an increased cardiovascular risk, when you want to lower HbA1c, and when you want to have additional weight loss. Why? Because we actually have good cardiovascular outcome data for all of these, for the whole group, to reduce heart attack, stroke, and ischemic events. So they all have their preference. So, and as you can see, dulaglutide is at the bottom as the easiest injectable. And I don't need to say too much because the other ones will not be funded. But they all have slightly different outcomes, but overall fairly similar, as already mentioned. So they all lower your HbA1c. The dulaglutide reduces the MACE in the larger studies. It doesn't have a cardiovascular mortality benefit by itself. This has cardiovascular benefit, but did not reach mortality benefit. whereas liraglutide has, and it has also a renal benefit. So that is the largest study, the REWIND study. New Zealand was participating in this study. That's a large cardiovascular outcome trial with dulaglutide. So as you can see, there were 371 centers in 24 countries. The age was 50 years upwards. So that's important to mention because when we use them, we don't actually have data or good data for people younger than 50 years of age. And these patients have all type 2 diabetes with either previous cardiovascular event or increased cardiovascular risk factors. And they were matched placebo with dulaglutide 1.5 milligrams once weekly, which is a standard dose. So it's a once weekly subcutaneous injection. And so that's the outcome. As you can see here, so we looked for a composite endpoint of non-fatal myocardial infarction, non-fatal stroke, or death from cardiovascular causes. So nearly 10,000 participants. And so the median follow-up 5.4 years. And so there was a significant reduction in the primary composite endpoint, as you can see, but the all-cause mortality did not differ between the two groups. So it just did not manage to pass the threshold. As you can see, the confidence interval just gone over the 1.0. And as said already, the most common side effects were GI side effects. And you can see the graphs from the studies. You see the outcome on cardiovascular outcome, on stroke. And that was interesting. The composite outcome was mostly carried by stroke. You see the impact on HbA1c, on blood pressure, on weight, but there is a small increase in heart rate. That's important to be aware of. Now, this is an interesting slide because they looked in the same study whether there's any group difference. So there was no difference by age, duration of diabetes, history of cardiovascular disease, baseline HbA1c, or BMI, maybe BMI marginally when you were bigger. But the biggest difference is where you came from. And you probably see the little dot, which I highlighted with a red circle, and the arrow going to the left. This little dot is New Zealand. So because we probably don't have much other medication available, we actually achieved a much greater benefit in New Zealand than all the other centers. So that's a good thing to know. Because we start relatively medication naive here, we have actually probably a bigger benefit than other countries have. So how to use it? So I used the Australian data sheet because there is currently no data sheet for New Zealand. So you can use it as a monotherapy or as combination therapy, but I think it is really an add-on medication based on the complexity of the treatment, the cost, as well as the add-on benefits. And I will show you some slides at the end. So as mentioned, reduces major cardiovascular events. And really it does or can be used in a fairly wide range, as you can see here, with mild, moderate, and severe renal impairment down to an eGFR of greater than 15. And there's no dose adjustment required on age, and no dose adjustment required on hepatic impairment. Contraindications are really GI disease. So if you have gastroparesis with autonomic neuropathy, that is clearly contraindicated. And if patients cannot tolerate it due to vomiting or nausea, that would be a reason to stop this medication. It's not to be used in patients that have a risk for pancreatitis or had previous pancreatitis, so patients who are alcohol dependent or have very high triglycerides. It should not be used in pregnancy and lactation, and it has not been studied to a degree in type 1 diabetes, and it's clearly not for the treatment of DKA. So you see another slide from the data set, very similar to what we had before with the old exenatide data. So you see the dulaglutide data, very similar. We talked about hypoglycemia and we talked about tachycardia. There was a small increase of heart rate and a small increase of atrial fibrillation, especially in the older population. And you can see here on the right side, I just put a slide in because it goes back to the slide I showed you before, where we talk about the first phase insulin response. So you see on the left side healthy subjects, you see the insulin response, and then the patients that actually on dulaglutide, they have a much higher insulin response because you give the GLP-1 agonist, which works on the pancreas, excretes more glucose, suppresses glucagon, you get a spike. And then on the right side, you see the two diabetic patients where this response is completely blunted, and then you get it restored with your GLP-1. So because dulaglutide has a long half-life, it can be given once weekly. And because it slows gastric emptying and works on the brain, it also has a weight-losing effect. Now, dulaglutide has a less weight-losing effect than liraglutide, but it still lowers your weight by approximately 3 to 4% of starting weight. Now, one other thing, and I will allude to this one because it will help you to say or to decide where to use it. There were 8 studies that actually, with phase 3 studies, really tried to home in where to use, when to use dulaglutide. And there's post-marketing studies ongoing. So I wanted to show you one case, and that's a real-life case I saw recently in clinic. So it's a type 2 diabetic patient who had type 2 for 10 years with difficult control, with multiple complications, as all patients, or most patients have that come to the center. He also had a strong family history for heart disease and type 2, and he was heavy. His BMI was nearly 40 with a weight of 126 kilograms. So we had an Edmonton obesity stage 2 with a WHO grade 3. He had hypertension, gout, fatty liver, and increased cardiovascular risk. So he was on the standard treatment, as most patients are, as you mentioned, on Novomix, and he was on top on insulin glargine. So he had around 170 units of insulin when he started, with a BMI of 40. He was on metformin to the maximum tolerated dose, blood pressure tablets, and some simvastatin. So what I did at the beginning, I started him what is available really, vildagliptin and pioglitazone. I don't want to say too much to pioglitazone, but if you deal with significant insulin resistance and have central abdominal obesity, it's a good add-on in a low dose. And we asked him to start monitoring his blood sugar. So what happened? I reviewed him in a telephone clinic during COVID. He came originally from Christchurch to Auckland. And as you can see, his HbA1c was never pretty good despite the high dose of insulin. And he works night shifts. He had found it difficult to comply with a rather complex regime. And as often these patients do, they withhold the insulin because of hypoglycemia. And as you often see, because they're so insulin resistant, they actually don't get very high sugar readings, even if they withhold the insulin. Now, he actually educated himself about the available GLP-1 agonist liraglutide and said, "Doc, what about this medication? Would it fit for me?" And I said, "Yes, it could." So he had no contraindication for a GLP-1 agonist. So what we did, we stopped his glargine, we down titrated his Novomix, and so we had a combination of insulin and the GLP-1 agonist. As I told you at the beginning, it is well possible to have this combination. So I continued to pioglitazone, and of course, we had to stop the vildagliptin. That's a very important message. If you start a GLP-1 agonist, you don't use vildagliptin because it's from the same group, and there's no benefit, and so that's clearly a contraindication. Well, a reason to stop it. That's his real-life data. So he started off when he saw me with an HbA1c of 92, and then he's down to 55. His fatty liver has significantly improved, and that's data I haven't shown you because both medications, the SGLT2 as well as the GLP-1 agonist, actually have good data for improving fatty liver. His lipid profile improved, his weight gone down marginally, not much, and he significantly reduced his insulin. So you see now he's on 70 units from something like 170 units. He's more active and he's doing well on the medication. So who's your ideal patient? So patients who have established cardiovascular disease or risk factors, as in the Rewind study and as in the proposed PHARMAC funding criteria, who already have established renal disease because it slows progression, reduces microbinuria, not as much as the SGLT2, but it does, and you can use it down to relatively low eGFR. Patients really need to be established on metformin and probably on other medication as well, because it's injectable and it works well if you have insulin. It works better if people who are heavier, as I showed you the data, and if you live in New Zealand. So don't forget to stop your vildagliptin. Now, that's one last bit of slides, or last slides about why we want to use it later on, not as a first-line treatment. If you see here in the red circles, this first study was monotherapy. So we're talking about dulaglutide compared with metformin. And you see there's a marginal improvement in HbA1c. That is basically 0.2%. That's probably 2 to 3 millimoles. As an add-on to metformin, compared with sitagliptin, which is like vildagliptin, you see a significant benefit. So yes, the GLP-1s are better than the DPP-4s, even if they work in the same group. And when you add it on to multiple other medications, you see a much greater benefit. And if you add it on to insulin, you see an even greater benefit. So yes, leaving you with the last slide. So really try to start your patients on what is available. But if they do not achieve good control, then it's a great medication to have for cardiovascular benefit, glycemic control, and weight. And it is most benefit when you add it on. Titrate it slowly. Nausea is a limiting factor. So what we do with dulaglutide, we start 0.75 once weekly. And then after 2 or 3 weeks, we can increase to 1.5. And that's similar with the liraglutide, which we titrate up. And you think about other medications that can cause GI upset. And there are a few little tricks to prevent GI side effects. And so I'll leave you with the last slide just to remind you on the guidelines. Thank you.
Great. Thank you very much for that presentation on the dapagliflozin and related medications. We'll take a few questions on that particular class, and then we'll take some broader questions just towards just before we sort of finish up today. So my first question for you tonight would be around that particular topic would be, with the dulaglutide and the nausea, is that something that settles with time?
Yes. So nausea, as mentioned, is the limiting side effect. It generally stops in the first few days. Now, I have to be honest, practicing in New Zealand, I don't have personal experience with dulaglutide because it's not in the country, so I can't use it, prescribe it. But I have good experience with liraglutide, and I had previous experience with exenatide before I came to New Zealand. So my recent experience with liraglutide is when the nausea stops roughly after 3 to 4 days when you go up 1 step. So the pen allows you to go up in steps of 0.6 milligram. So you start 0.6, then you wait for 1 week. If your nausea settles within 3 days, you can go up on a weekly interval. If it doesn't settle, you stretch it out for 2. So I assume that we will do the same with dulaglutide. So we titrate if the nausea settles. We stay on the lower dose if the nausea doesn't settle. Now, from the patients I started, I roughly had 30% of patients I had to stop because of side effects, and 2 of them were because of nausea and vomiting.
Okay.
It's relatively common. And I just saw one patient this afternoon on the liraglutide, and she went up to 3 milligrams and she couldn't tolerate the 3, but she was fine with a 2.4. So most patients will tolerate the lower dose if you titrate them slowly.
Okay. Now, you talked about one of the side effects of gastroparesis, not side effects, sorry, but one of the things that we should avoid giving the these medications when someone has gastroparesis. Excuse me. So I guess the question there is it due to the fact that it's delaying gastric emptying? Is that the reason why we don't want to add on that particular medication for that particular circumstance?
Exactly right. So this has basically, the effect is slowing gastric emptying, and it has pros and cons. So therefore, you cannot use it in gastroparesis, which by itself is a delayed gastric emptying, but it works on the other side very well for people who have a rapid gastric emptying. So people, for example, who do binge eating on a buffet-style meal, who are hungry 2 hours after meal, it works very well in this group. But gastroparesis, that's the reason exactly.
Okay. And someone's wondering in the audience whether or not any of these medications can be restarted or used after someone starts dialysis.
We don't have dialysis data as far as I'm aware. So I would say that's not your medication for dialysis. So if you're on dialysis, you should be on insulin. The other thing, what I say, a lot of patients, especially type 2s, once they're on dialysis, need far less medication. Their main risk is hypoglycemia. So I would normally stop all antihypoglycemics and would have them just on a small dose of insulin.
Okay, great. Can these two different classes of medications be used together?
Yes, they can. Now, PHARMAC decided that they don't want us to use them together, but that's, I think, a financial decision. But yes, as the guidelines show you, and I can go back to the slide, people can see it actually. No, that's one here. So as you can see, it's basically you add it on. So you can have both. Because, as I mentioned before, you can actually mix and match because these drugs work from different mechanisms, a little bit like with blood pressure tablets. So you have your ACE inhibitors, you have your vasodilators, you have your beta blockers, you have other drugs that actually work from different ways how we treat blood pressure. Same you can do this one. So you can have a GLP-1, you can have a DPP-4, you can have insulin, you can have pioglitazone, you can have different groups together. The only thing what you cannot have is a DPP-4 and a GLP-1 because they work from the same group.
Understood. Thank you. Now, we've talked about how these medications are useful for those that have cardiovascular and renal issues. Mm-hmm. So what about our diabetic patients that have neither? Do we maintain them on metformin? Is there another choice?
Good question. I believe you need to also use medication in the right possible way. Now, as I showed you with the last slides, if you start a patient straight on dulaglutide, you get a marginal benefit over metformin. So I think we should still stick, everyone starts on metformin except you have a contraindication. If you then have patients already established on, say, a DPP-4 inhibitor like vildagliptin and metformin, and they're doing fine, and then you don't have to do anything. However, if you have a patient like the case that I showed you this evening, where you need further action, where you want to reduce the insulin, where you want to improve their cardiovascular outcome, then they are good add-on medication. And I also say this one because we don't have much experience in primary care in New Zealand. I recently prepared something for a meeting with PHARMAC and looked into what they're doing in the UK. And the GLP-1 agonists are actually secondary care initiation and primary care continuation, a little bit like you had it with the Entresto. So therefore, I believe it's probably not your first line choice, especially not for the GLP-1. And as you get more experience, I think then it becomes more earlier on. But I think we need to be also mindful who benefits the most from it.
Okay, great. Now, someone has posed an interesting question. So when we think about the way that we've been managing our diabetic patients in the past, and sulfonylureas were in the mix, so to speak, is there a role for them now? with the advent of these new medications coming to fore, where do you see the place of the medications that we used to use, such as sulfonylureas?
Good question.
Forward?
As you can see in the slide in front of you, only in the right corner you have sulfonylurea. So in, say, Europe or in the US, people have moved away from sulfonylurea. We have a lot of experience, so I don't think everyone on an SU need to be changed over. Now, they have generally relatively good safety profile, except when you have patients who get hypoglycemia. So I would not recommend everyone who's well established on the SU to change over. I believe they work well for a certain group of patients who have low risk and who don't carry significant excess weight. However, as we get more familiar with the new groups, we will most likely prescribe far less sulfonylurea than we currently do. So they still work very well if you have moody diabetes, monogenic diabetes, because that is really where they fit very well. They work well if you have LADA, latent autoimmune diabetes of the adult before you start insulin. And they probably work well for people who are currently established on them and have no cardiovascular risk.
Okay, great. Now, you would have gone through a little bit of this with your case studies, but just thinking about that space in insulin and just sort of acknowledging the fact that these medications are very new for us. So to remind us, firstly, with these medications, is this something that you'd start before you'd start insulin?
Good question. So I think there's no choice either way or the other. What I can say in the UK, when I looked in the other data, they actually had to restrict the use of the GLP-1 agonists because people started to use them too much and didn't use insulin. So I think every medication has its use. So now you have to put it into context. If you, for example, want a rapid reduction of a high HbA1c, I think an insulin start is still the right thing. If you have any contraindication to the new medication, insulin is the right thing. If you don't have experience with a new medication and you want it to be started in secondary care, insulin start is the right thing. So don't delay your insulin start because you might wish to start a new medication. So insulin is still a good choice. However, if you have an obese patient with an increased cardiovascular risk who doesn't want to gain weight and you feel comfortable with using the medication, you can start them, of course, before you use insulin or instead of insulin.
Okay. And with one of your case studies, when we started, I think it was the second one, when you started on the injectable, you titrated down the insulin. So that would be a standard thing that you'd consider in context of your initiation, or would you monitor and decrease, or is it individualized?
Yes, so both the SGLT2 and the GLP-1s can cause hypoglycemia if used together with insulin or a sulfonylurea. So you will have to down titrate. So when we start them, so we need to say monitor. It's a little bit, if you start with a very high HbA1c, but we don't see too much. But as this case, sure, I'm not sure whether the audience can see it. But if patients on very high doses, you will need to significantly reduce your insulin because you will also experience weight loss. And with weight loss, you reduce insulin resistance. So therefore, you will need less insulin. So this insulin gone down significantly because I started another insulin sensitizer in the form of pioglitazone. So that's why you probably saw the significant decrease. The patient was on 2 insulin sensitizers plus the newly started GLP-1 agonist.
Okay. Someone's wanting to know if an individual has atrial fibrillation, do GLP-1 receptor agonists, do we need to avoid using them?
There's no data to avoid them. So what people found in the large studies that they found there's a small increase in risk. So if you have established atrial fibrillation, I think it's fine because you are established on it. If you probably just had someone who got cardioverted and is at a risk and waiting for ablation, it's probably not your choice of treatment. I think you just have to put it in your clinical context.
Okay. As we move forward into this new era of these new medications coming into the fore, would you be able to give us some, I guess, last key points in terms of beginning to think about our patients ahead, who we may begin to audit and consider individuals that may benefit from these medicines, just to kind of nail it in there so we can take it away and begin and initiate that process, looking forward to that new funding of these medicines in the future?
Thank you. I think it's a brilliant question to end, because to achieve equity in the end, it is not only important to have access to these medications, but actually to provide comprehensive diabetes care, as I showed you at the very beginning. So some PHOs looked into actually going through their lists and identifying patients that have cardiovascular disease or risk factors with poor glycemic control. So I would say every time you see a diabetic who has microvenuria, renal impairment, heart disease, obesity, and you want to do something, and you have this new medication available, I think start thinking about it. Now, if you feel that is difficult, then ask for help. In secondary care, we're preparing ourselves at the moment to be asked much more frequently. We're training our specialist nurses up to be prescribers in the future, or we anticipate non-slot, so to speak, once this medication is funded. And I believe it is a good idea for people who haven't used it to use some guidance while you started, follow documentation. There will be more documentation coming out, and then ask for advice, but look proactively out for the patients group I just mentioned.
Great, that's a lovely end point and a really good key memory that we'll take away from this particular webinar. Now, thank you so much again for coming in and talking to us about this. I've learned a whole lot tonight, and I'm sure those in the audience have as well. So just to let you know, everyone, this is our last webinar for 2020, and what a year it's been. Thank you so much for joining us on our education series. I recognise a lot of the questions from certain participants coming up through the series during the year, and it's been great to have that interactive part of this education series. I want everyone to take a break, have a lovely holiday, and we will see you in early next year. So good night, everyone,